I am Nagashree Seetharamu, Associate Professor of Medicine. I'm a thoracic oncologist. I'm at Hofstra Northwell Health in New York. I will be presenting on lung cancer, and I'll be focusing on local and locoregional disease, as well as a couple of studies in small cell carcinoma and mesothelioma. So what did we have exciting at this ASCO 2021? It was a virtual format, which was unfortunate. However, we had quite a few exciting studies in lung cancer. Some of them I want to highlight, or really, there were some pending questions that were kind of nailed in this ASCO. One was surgical options, VATS versus open surgery, a question that has been haunting the surgeons for a very long time. And again, the VATS group did superior. VATS was superior to open surgery in all outcomes and had the same type of oncologic outcomes as an open surgery. There was less adverse events, and there was also less hospitalizations and post-hospital events as well. So, and the quality of life and patients who received radioscopic procedure was superior compared to patients who received an open procedure. So that question was answered at this ASCO. The second question also has a long-standing question, is the stereotactic ablative radiotherapy in operable stage 1 non-small cell lung cancer patients. This is actually an extension of a previously conducted randomized study where SABR was compared to a surgery in early stage lung cancer patient. SABR was noted to have superior outcomes, particularly in terms of overall survival. However, that study had a lot of concerns raised. One was that it was a small study. Not all patients who underwent surgery had a radioscopic procedure, as would normally have been done. So they extended the surgery as a single-arm study, and additional patients were enrolled between 2015 and 2017, and they looked at overall survival and compared it to historical details from patients who had undergone VATS procedure. And again, this demonstrated that patients who underwent SABR for early stage had a 3-year overall survival of 91%, 5-year survival of 87%, and a 3-year PFS of 80%, and 5-year PFS of 77%, all non-inferior compared to historical data from VATS. So that also answered one question, which is SABR is an appropriate approach for early stage lung cancer. However, it is really, really important to discuss this at a multidisciplinary setting. So that's the second question answered at this ASCO. Next is neoadjuvant treatment for early stage non-small cell lung cancer. So we've seen a lot of results, phase 2 and as well as a phase 3 data come out looking at chemotherapy plus immunotherapy or immunotherapy alone versus chemotherapy in the neoadjuvant setting for resectable lung cancer patients. The question has been, does immunotherapy result in higher mortalities, surgical mortalities? Does it result in more difficult surgeries? Do patients undergo more invasive procedures? And I think at this ASCO, those questions were clearly answered. Patients who underwent immunotherapy plus chemotherapy as part of phase 3 study did not have any increased complications, surgical complications. In fact, numerically, fewer patients underwent a transformation from a minimally invasive procedure to an open procedure if they had been previously treated with Nivo and chemotherapy. And numerically, more patients underwent minimally invasive procedure compared to those who received chemotherapy alone. So those questions were clearly answered as well. Side effects, quality of life were all superior in patients who were all equivalent in patients who received the two. Pathological responses we had seen previously, amazing difference between those who received immunotherapy plus chemo compared to those who received chemotherapy alone. Depth of response was also significantly improved in those who had additional immunotherapy. So that question was also answered. Moving on to adjuvant treatment. An interesting result was presented. This was the first publicly presented phase 3 study combining atezolizumab as an adjuvant treatment after completion of adjuvant chemotherapy in resected 1B through 3A non-small cell lung cancer. Showing excellent progression-free survival benefit. Is DFS, is that an appropriate endpoint, primary endpoint? I think the Adjuvant study with the EGFR has established that, so I think this is very promising. We look at 74.6% of patients being disease-free at 24 months compared to 61%, and 60% of patients being disease-free at 36 months compared to 48.2%. This is impressive. The curves are just speak for themselves, and most of the patient subgroups were benefited from this. The overall survival data is very immature, but just looking at the previous examples, particularly the Adjara, I think this is very similar to that, I would say, in terms that it did prove the point. This was the endpoint that they chose as the primary endpoint, and it did show that it was superior. The side effect profile was not anything different. There were no surprises. All immune-mediated adverse events were similar to what we've seen with this class of drugs. So again, a very a provocative study, and I think potentially something that may change. It may be practice changing in the future, but time will tell. Two additional studies with tyrosine kinase inhibitor, one with gefitinib and the other one with erlotinib, showed that these are not drugs that you would normally use after surgery in lieu of chemotherapy. Chemotherapy continues to be the standard of care in resected early stage lung cancer patients. So these were two negative studies, but they nevertheless did drive home a few points, and that is, it cannot be really substituted. And how does that play in the face of a Adjara study, which showed a clear difference in disease-free survival? Early generation drugs are definitely inferior compared to the third generation osimertinib. In mesothelioma, I'm not, oral vinorelbine is an effective drug, that can be used in subsequent lines of treatment. The study was not impressive, but did show that this would be an effective drug. So if we're looking for an additional option for patients, vinorelbine is something that can be considered. In small cell, not many studies presented, but I think the one study by Dr. Bogart kind of, again, answered one question that has been haunting the radiation oncologists, which is whether once daily thoracic radiotherapy is superior to what we now call standard twice daily treatment. Twice daily is somewhat logistically difficult because of the time difference. The patient have to stay in the center for a very long time, and not everybody have access to such care. So again, the study did confirm that the longer duration, high intensity treatment is not superior to what is now considered standard of care. However, it is probably the best evidence that anybody will probably get about this particular intervention in this disease. And I think it's probably practice affirming. I think you can go either way. You can do twice a day, or you can do once a day. And I think you would pretty much have equivalent outcomes. Thank you.